very essential about what would be an ideal. Ideal need not be easy, and as Naresh was pointing out slide after slide that it is so difficult to do in the field. Why is it important? Because the diabetes is increasing in prevalence, and it is recognized now as by WHO that it is a global problem, and it requires a holistic approach rather than a disease which is limited to eye or only part of the body. And it's going to be a leading cause as ophthalmologist for us for a leading cause of blindness. So we have to deal with it, and it is very much preventable. And when you see the global scenario, can I have the pointer? India is leading country to have most number of diabetics, and in no time I think most of our clinics will be full of diabetics. And in developing countries, one can observe that it affects the age group which ends for the families. So it's not only the person who is getting affected, the whole family gets affected. And everyone knows the figure of 80 million, which is going on for a very long time, and currently it's crossed for 40 million actually. This is the old figure around 2000. And if you see the prevalence by different studies, prevalence of diabetes is almost 7 to 10%, which is there is a urban-rural variation is there. 4% is for the rural, and urban it is touching 10%. Like 1 in 10 person is having diabetes, and prevalence of diabetic retinopathy is almost like 30% of the diabetics. And there are different screening modalities that has been adapted in these screening programs. The 20D, 70D examination fundus photography. And this is an LVPI model, though right now I am not in LVPI. This model is close to my heart because we have designed a program, diabetic retinopathy program on this, and then WDF, World Diabetic Foundation has funded this screening program. If you see from grassroots, villages will form the closest nodus of around 5 to 10,000 people in the villages, and then when it comes to 10 such villages, one vision center need to be available so that they can screen their eyes preliminarily, and it can come to a rural eye care center where the ophthalmologist should be available to grade the diabetic retinopathy. The vision center, the function is whether there is any abnormalities there or not. Only to that extent they can grade. After that, it comes to the ophthalmologist who will grade what is the stage and any treatable diabetic retinopathy is there or not. And if at all required, a laser can be done there. Surgery can be referred to a tertiary care center. Here are the agents who will be treating the patients. This project, which the World Diabetic Foundation has funded, is mainly aimed at strengthening the capability of public health facilities, which will exist forever. If I have given the facility, it will exist forever. Screening camps has an inherent weakness of going for one time stimulus, and then it will come back to the baseline. So you need to upgrade the care that is available for the society. That's where it is targeted, and establishing a working network of experts within the vicinity of that community so that the whole community gets upgraded. And education and training, periodic education and training of the health workers is very, very essential because they also can forget about the things. And comprehensive screening of all the identified diabetics. First of all, you need to identify. First challenge is to identify whether it is diabetic or not. Second challenge is to identify diabetic retinopathy is there or not, and other allied elements. It is not only diabetic retinopathy that should interest us. Even in the clinic I do this. I check for a whole system rather than only eye. And how to do the activity? High risk determination. It is the high risk score that is important. It is depending upon the family history, physical activity, and the dietary activity, and everything, and obesity, weight, height and waist ratio. That is more important. And above 60 will be taken as a high risk group. And this high risk group can screen by a blood test, not by urine test, because urine is not a sensitive test. And then ophthalmic screening and a physician screening can be done, but physician and ophthalmologist need to be sensitized for a cross system examination. That is more important, which most of the time it is lacking. So at the community level, a diabetic patient, self-help group, RMPs, we have taken the help of the registered medical practitioners. Though they are not official practicing physicians, lot of the villagers have a lot of belief on these people. So we have taken them into confidence while helping in screening. At organizational level, government health system, at Andhra Pradesh, there is 104 services are there. It is mainly under Arogyasri they are helping this, and philanthropic organizations and NGOs. And individual level, general physicians and specialist team is been identified. And these are the equipment that has been given for at different levels. And eye care delivery at the community level, vision center level, secondary center level, and tertiary care center level is been indicated here. And different activities that has been carried out by each agent, that is health worker, physician, diabetologist, and the specialist. So overall, in conclusion, what I would like to say is diabetes is assuming definitely an epidemic proportion, and there is an urgent need for global as well as national strategy to tackle. It is, as Naresh was pointing out, and each slide he was mentioning that it is so frustrating to do a screening camp as well. Because when you go, I went to even households where when we go, they tell about other problems because they have other priorities. Certain times food and clothes are their priority. Day-to-day electricity is their priority. Sanitation is their priority. Somehow we are sitting in the clinic, we don't understand their priority, and we need to match the frequency between the households as well as our requirement. So both the things need to be matched. So while interaction, this is one lacuna which I found that we need to bridge it to make any diabetic program very effective. And here the government involvement is also equally required. Unless the government is committed for a diabetic screening or awareness, it is not going to work, because we individuals, we cannot cover the whole country, and the population in large, it is a vast population, so we cannot address such a vast population by individual organizations. And our project model, it is only an ideal model. As I said in the beginning, it is an ideal model, but it's very, very difficult to implement in every state or every corner, nook and corner. And there are challenges while implementing this kind of a model. Thank you.